Kia ora koutou, I'm Russell Brown and I write about drugs because it's really, really interesting. And there's probably no field more interesting at the moment than psychedelic science and psychedelic therapy. In fact, in my taxi on the way in from the airport yesterday, the entire journey was what became quite a high-level conversation about psychedelic therapy with my Sikh taxi driver. Which I took as an indication that this is actually getting through to the mainstream. In this session, for this session, I wrote about 2 hours worth of questions for half an hour's worth of kōrero. We're not going to get to all of it, but I hope what we can explain in this session is, firstly, a little bit about how psychedelics work and where and why they might help, and also what the issues are. And among the issues, of course, is our old nemesis, the Misuse of Drugs Act 1975. We meet again. It's still there in the corner stinking things up. So there's a lot of hype, but increasingly a lot of reality. And to talk about that, our panellists will make a short presentation each on where they're at and what they're doing, and then we talk. First up will be Dr. Suresh Muthukumaraswamy, who's an associate professor at the University of Auckland working in the School of Pharmacology. As part of a postdoctoral fellowship some years ago, Suresh did the neuroimaging on landmark psychedelic studies conducted at Imperial College London. So he literally knows what your brain looks like on drugs. More recently, he's been leading the Auckland LSD microdosing trials, and he has data from those. Right on the end there, Manu, Caddie, someone a lot of you will know. He's the co-founder of Matawai Bio. He's done many things, but currently he's back focused on IP development for pharmaceuticals, natural health products, and bio-derived composites, basically things that come out of the whenua here. He's one of the leads on the Waikato project, which we'll talk about, which is absolutely fascinating, which aims to harness the healing potential of indigenous fungi. In the middle there with the beard, Dr. Mitchell Head, who is also working on Waikato. He's a neuroscientist working as a postdoctoral fellow at Te Kotahhi Research Institute and a lecturer in the School of Science at the University of Waikato. Among other things, he's investigating the use of psychedelic-assisted therapy for mental health, especially in a Te Ao Māori context with native taonga species. So you can see why those two are together. Next up will be Jacek Cotogni, who comes from a completely different world than the rest of our panellists. Along with his sister Michaela, Zach is the author of Blue Honey, a collection of accounts of New Zealanders who've experienced healing through the use of psilocybin mushrooms. He advocates for improved access to psychedelic therapies for everyone. And, where are you? In the blue jacket, Dr. Jacek Kolodziej. His field of study has been sexual health and in particular HIV prevention. He's now the policy director of the New Zealand Drug Foundation. So that's sex, drugs. He's only got rock and roll to go. Anyway, I'm glad that joke landed. Let's crack on because there's lots to talk about. So with the first of our presentations, we'll have Suresh.
Kia ora koutou, thank you. Thanks, Russell. Am I going to get slides? Maybe? Oh, yeah. Okay, great, thank you. So my remit is, I think, not to so much talk about my research, but to maybe just give a quick introduction to psychedelic medicine, just so we're all on the same page for the future discussion. So first question probably is useful to to ask is, well, what are psychedelic drugs anyway? And there's complicated ways that we can talk about the pharmacology of it, depending on receptor systems and drug classifications, et cetera, and everyone disagrees about what actually a psychedelic drug is, and honestly, it doesn't matter. It's just this human need to put things into categories and to label things, and it actually is kind of pointless in a way. So the answer and the thing that you can just think about psychedelic drugs, they're drugs that kind of make you think unusual thoughts and make you maybe reframe some of the ways of thinking. So we'll just leave it at that and not worry too much about these categorical type definitions with these hard boundaries. We don't need to go into the details of this slide. This is just to say that we know a lot now about the neuropharmacology of how some of the drugs that we're most interested to talk about today, like psilocybin and MDMA, we know a lot about now how those work at a cellular perspective from the science that we've been doing. And we've got a moderate understanding of how they work in the human brain when they're given to a human. And that's really just a precursor to that. It's a whole semester of teaching on that, so we'll skip over that. So psychedelic medicine has now become really, really widely studied worldwide. This is just a kind of brief summary of some of the research programs that are happening worldwide. So clinical trial development goes in different phases. Phase 2 is we're starting to try this out on different patient groups. This is, on the left-hand side, some of the different disorders that are being studied. And on phase 3 is kind of the last steps before regulatory approval. You don't even need to really see the details there. It's a long list. So there is a lot of investment being made by companies into pursuing psychedelic medicine to get some products into armamentarium. And this comes with a lot of dollars involved. So it's thought that the global psychedelic drug market for treatments, by the time we hit around 2030, will be worth about $7 billion per year. So we're talking a lot of money, and a lot of venture capital money is flowing into this area as a way of potentially treating various conditions that we'll talk about. So in terms of what the lead candidates of what's coming down the pipeline, the most mature of these is the use of MDMA-assisted psychotherapy for severe PTSD. So I don't know if this actually has a pointer. Yeah, it does have a pointer, but only one of you will get to see it. So what you can see here, this is people's PTSD symptoms, and in the red you can see basically improvement. These are people with treatment-resistant PTSD that have failed all other therapies, and you can see significant improvements in their PTSD. The treatment protocol is very complicated, and one of the things I want to stress about the way that psychedelic therapy works is it's not just giving people a drug and sending them on their way. It's psychedelic-assisted psychotherapy, so patients are given this given the psychedelic, but then they're accompanied by a psychotherapist, and it's not just in that dosing session, which lasts a day. There will be weeks of psychological and psychotherapy work that is done afterwards. They have these unusual experiences, and they talk with psychotherapists afterwards to try to work out how this might solve some of their psychological problems. So it's not just giving someone a drug and sending them on their way. It's more complicated than that. Similarly, the other leading candidate for psychotherapy is single dose is psilocybin in treatment-resistant depression, and we can see here the blue line is high doses of psilocybin compared to placebo conditions, and we can see a large decrease in depressive symptoms. One of the questions that we'll pose to the panel, though, is so yes, there's a lot of psychotherapy involved. Are these black box American and British psychotherapy traditions, are they going to be appropriate if these black boxes are just pushed into New Zealand at some point by a multinational corporation? Whether those are going to be appropriate for our population, I venture probably not. Some of the other panelists will talk about that some more, I hope. And then finally, let's just so you are aware of what's happening across the ditch. In Australia, a couple of years ago, the right-wing Morrison government, someone there had the idea, let's pour some money into doing some research into this. So they put about $15 million was invested into psychedelic-assisted psychotherapy research. And there's a whole bunch of trials happening across Australia in that. And some of those trials most of them are kind of midway through at the moment, starting midway finishing. So a large investment has been made by that government into actually research and building capacity. And then just a couple of months ago, the TGA, which is the equivalent of MedSafe there, the Therapeutic Goods Administration, they have actually reclassified psilocybin out of the poisons control standard. so that from July the 1st, I think it is, July the 1st, psychiatrists will now be able to prescribe psilocybin for treatment-resistant depression and MDMA for post-traumatic stress disorder. So that's going to be happening very shortly across the ditch. And I would like to have a slide about what the New Zealand government has done in this space, but I don't need to, because there's nothing to present, because that's where we're at in New Zealand. So that's my talk, and I'll leave it to the next one.
Nā tēnā tātou, uri tēnei no Ngāti Haua, Ngāti Pukenga, engari ka noho au raro te maru o Hukarangi Maunga, runga te whenua o tōku hoa. I live just outside Ruatoria on the east coast, and was approached a few years ago, 2 or 3 years ago, by a local GP who works for an iwi health provider in Aotearoa, and he had been reading some of the research on psilocybin fungi and knew that we were involved in manufacturing legal cannabis medicines, and was asking if we could maybe do something together. So I reached out to the most progressive marae in Aotearoa, Rangiwaho, which is just south of Gisborne, and talked to some of the trustees there, and they were super keen to explore the opportunity to do some research on native fungi, psilocybin mushrooms. And so I talked to some people I knew at Manaki Whenua, Landcare Research, Crown Research Institute, about how to identify which ones were native and which weren't, and they were very helpful, and came down to Rangiwaho for a wānanga, and we had a forage in the ngahere and found some werero specimens, which are those fungi on the left there. Things have progressed from there, and we've got another CRI ESR involved, and choice to see you, Mary Jane, and the support that we've had from them has been awesome as well. So while the politicians may equivocate, the researchers and Crown researchers are very supportive. Mitch is here, he's going to talk about his involvement from a neuroscience perspective, and we've got some good medical researchers involved, and some normal practitioners who are helping with the cultural therapy side of things. So the idea is to have it's not just about a product, but about a practice based at the marae that's specific to Rangiwaho, and the species of fungi that grows in their backyard. And Matawai is a research institute in Gisborne that's also involved, and they do MRI brain scans, so we've got that capability included. And community enthusiasts, there's a good community of fungi users in the country, and they've been very supportive as well. I wasn't sure how they'd feel about it, but we're getting donations from them through to ESR to compare the local varieties with other werero from around the country, and working through some of the issues there with kaitiaki and thinking about how we involve those other communities in the project. And some of Suresh's colleagues at University of Auckland have been helping us with a clinical trial protocol that's going to go alongside all of this. So it's a very collaborative project, and my focus has been on the regulatory pathways, and particularly the treaty implications of this, and the issues around the controlled drugs legislation and the Crown's assumptions around their right as the Crown to its right to control native plants, indigenous taonga species under that legislation. And it goes back to, there's a 1971 convention that requires state parties to regulate psilocybin fungi and have a lot of control around that, but we've also, go back to the treaty, there's an obligation on the Crown to protect kaitiaki's rights and responsibilities to control their taonga until such time as they want to hand it over to the Crown, and I'm not aware of that ever happening. So we'll be progressing that through, and we've had some support from Te Puni Kōkiri, which has been awesome to explore those legal avenues. and issues, but also looking overseas at different jurisdictions and the way that they're treating traditional medicines, and have provided regulatory pathways for Indigenous peoples to utilise their taonga that they have for generations. And we hope, sort of by this time next year to have a good understanding of that, and we've tried approaching the ministry, and it's a little bit above them in terms of those treaty issues, so appreciate that they've got the legislation they're responsible for administering, and so it's probably at the political level that we'll need to have some good engagement around those issues. We've talked about treaty claims and things, but we don't need to go there if we can make the arguments. So that's my part of it, but it's part of a much bigger project within the community, and we've got a little website set up so people can go there and find out about the project as we progress. And it's not funded, it's a very not-for-profit approach. We're not trying to be part of the billion-dollar industry that's emerging. It's really about trying to make a process that's going to heal people, and we're really focused on addiction, particularly methamphetamine, which is where this GP mostly works, but potentially other addictions as well, using this taonga to help with that. Kia ora.
Tēnā tātou, ko Taupiri te Maunga, ko Waikato te Awa, ko Tainui te Waka, ko Ngāti Mahuta, ko Ngāti Nahona Hapu, ko Mitchell Head toko ingoa, no Nārua Wahia ahau. Kia ora everyone. I am a neuroscientist at the University of Waikato, and I'm really interested in the potential for psychedelic assisted therapy for the treatment of overcoming intergenerational trauma. So that's quite exciting. So I'll just make some quick logical arguments. The first point, Aotearoa has a mental health crisis, and we are in deep need for a new tool to address this. Secondly, today's mental health issues have been exacerbated by the effects of colonisation, as you can see here. Interestingly, that trauma may be passed down generationally, as you might be aware, and this can even be on a biological level, that it's changing the gene expression in later generations. So this can change your gene expression from that trauma, and it's very hard to escape and improve when you're stuck in the survival mode. Again, the Crown has an obligation to deliver equitable health outcomes, but by collaborating with Matauranga Māori, there may be a solution to this issue. So this is really interesting work that's just come out of Australia. A recent paper in the Frontiers of Psychiatry suggests that psychedelic-assisted therapy could be used to treat intergenerational trauma. So there shows in the study that there's trauma-related changes to DNA that is improved with psychedelic-assisted therapy. This is really interesting when you look at the discussions with this. Sometimes people are consciously processing these highly emotional experiences, and they might not even be their own lived experiences, but consciously processing their tupuna, their ancestors' lived experiences. And by going through the psychedelic-assisted therapy, they can start to consciously process this trauma, accept it, and move on from that, and then they're changing on a biological level their DNA and stopping passing on that trauma to the next generation. So this has some potential. It's only preliminary, but it has potential to perhaps stop and rescue intergenerational trauma, as we can see here in the DNA methylation that can be addressed and undone through psychedelic-assisted therapy. So it seems to be a really powerful tool to help you process this emotional trauma and perhaps change on a biological level this trauma from being passed down in the next generation. So in Aotearoa, there is Matauranga Māori around the traditional use of these species, maybe not going back a long time, but in recent times, especially with these taonga species. So you can see here this article recently published by the New Zealand Drug Foundation about our research in collaboration with the Rangiwaho Marae Nai Tā Manuhiri in the Tairāwhiti region. So our goal here is the co-development of a Te Ao Māori psychedelic-assisted therapy in a marae setting. So not in a clinical hospital setting that doesn't feel like home and doesn't connect to you, to me. It is in our own setting. And so we're trying to co-develop it with the whānau, that it is done in a way that is meaningful and from a worldview that connects with the patients. So that's been, yeah, I'll just move on to the next one. So we can see here that psychedelics can be a catalyst for new growth. This really interesting study shows that psilocybin induces rapid and persistent growth of neurons. So this is some of the work that I was doing in a postdoc, same kind of imaging here, where you can see neurons through a microscope. And when you put psilocybin onto them, they explode with new growth. So that's really exciting, because this provides an opportunity, with the correct practices wrapped around the medicine, for new pathways to form and break the cycle of addiction. It's not a magic cure, but it is an opportunity, a window of opportunity, to make new pathways in the brain. And this is just a catalyst. So what you do with that medicine and what kind of practices you put around the medicine is very important. But it is sometimes said that psychedelic experience is like shaking up a snow globe. It's disrupting the unhealthy patterns that the brain takes, because they're the trodden paths that are easily taken. They were what we've done before, the habits that we've had before, and can put energy into the system so that you can take a new pathway. Just like we see on the microscope. When you put the psilocybin on, it makes the neurons grow and a new pathway can form. And so you can see these paths in the snow. You can shake up the snow globe and create a new pathway. So it's very important what kind of practices we put around the medicine, because that can create which pathway you're going to form into the future. So Australia and others are moving quickly based on this very strong scientific evidence. And this has been said that it's perhaps the most promising development in modern psychiatry. There's a significant opportunity here for Indigenous innovation. And the question that I just wanted to leave you with is, will we be left behind and deny our people this opportunity? So let's collaborate. And I'd like to acknowledge Rangi Waho Marae whānau from Ngāi Taumanu for leading this kaupapa. We are here to support this, and our collaborators and friends here on this panel, Te Kotahi Research Institute, University of Waikato, New Zealand Drug Foundation, and that's it. Thank you very much.
That ringing's annoying, eh? Kia ora, everyone. It's an honour for me to be here today, but I've got to say, it's a tad intimidating. Never in my life have I spoken in front of an audience, let alone in Parliament, so bear with me. I'm an ex-drug addict to multiple substances, which included meth, opiates, and pharmaceuticals. But my biggest enemy was alcohol. The drug addictions primarily hurt me, whilst my drinking was hurting the people around me. It is thanks to psilocybin that I can now say I haven't had a drink in 6.5 years and have no more addictions. I'm happily married with my second kid on the way to the woman who stood by me through all the chaos and seen me out the other side. My sister Michaela experienced severe trauma throughout her childhood and adolescent years. She was a patient in the mental health system for 11 years with no change for the better or any real successful results. Suicide was high on her agenda. I was about 2 years into my healing journey when I heard that Michaela was advised to go back on a medication that she had been on once before. To her, this was a death sentence, as her body and mind did not react well with it the first time. I knew that something needed to change or we could lose her. After the positive impact psilocybin had on me, I sat her and our parents down and pitched the idea that this could work as an alternative. Well, that conversation happened 3 years ago, and today my sister is no longer a patient in the system. She is off all prescription medication, and now lives in Canada in search of psychedelic-assisted therapy to further her healing. To put this in context, thank you. To put this in context, there were times where she couldn't leave the house for months on end due to her health and the cross-combination of medications she was on. Michaela and I both had profound healing outcomes with psilocybin, but both for completely different reasons. We wanted to let the world know, but how do you shout from the rooftops that a Class A drug has changed your life for the better? Surely we couldn't be the only ones who had been on this journey, and we were right. After diving into the online mushroom community, we connected with people who had had similar positive experiences. This is where the idea for the book was born. Blue Honey is a collection of stories from people across Aotearoa documenting their personal healing journeys with psilocybin. All vastly different stories, but with very similar outcomes. Dr. Gabor Mate has read and endorsed this book, and though he mentions that the stories may be anecdotal in nature, Michaela made the very brave decision to not only share her personal healing journey, but to also release all her medical records from doctor visits, hospital visits, prescriptions, dosages, and all her files from her time in the psychiatric unit. I'd like now to share just a couple of words from a couple of our book contributors. This is from Aidan in Tauranga. Personally, I feel mushrooms containing psilocybin saved my life. They took me to the core of my problems and helped give me the strength and patience to understand and work through the jumbled space that was my head. It taught me a lot about myself as well and what triggered those mood swings. It was good to help me to get inside my head and fix the problem at the source. Day to day, as I'm sure many other people do, I talk to myself, and it gave the voice in my head a more positive and louder attitude. It's me and my best friend up there now. This is from Elan, from Taranaki. I think the other big takeaway mushrooms containing psilocybin often provides is a realization of just how much of our current society is deeply artificial and superficial by design. As much as it's made out to be important, so much of what we worry about or pursue doesn't really matter. Breathing, hydrating, sleeping, eating, loving, that's the stuff that actually matters. But what is expected from most of us, what we are forced into or feel obliged to do, is so often meaningless and ultimately unnecessary. No wonder everyone goes crazy. It blows my mind that I could walk out of here today and go to a bottle shop and get myself a litre of Jack, all perfectly legal. The consequences of that legal trade could be fatal. But that the act of exploring my own consciousness and the privacy of my own home with something that grows in the ground makes me a criminal, even though it's made me a better human being. This is upsetting, disappointing, and unjust. With the current state of this country's mental health crisis, domestic violence and suicide rates, something drastically needs to change. Thank you.
Just while Jacek's going up there, first time speaker gets the division bells, the power tools, and the emergency siren. Nice.
Kia ora koutou. First of all, wow, Zach, that was stunning. But I wanted to thank Suresh, Manu, and Mitchell, and Russell for being with us today and sharing the stories and their knowledge. So the aspect that I would like to touch upon today is regulation, and in particular looking at some of the regulatory models overseas and trying to distill some learnings to inform future policy in Aotearoa. So I will focus on psilocybin, but some of those learnings may be also applicable to other psychedelic substances. So despite being a Class A substance, psilocybin is consistently ranked as one of the least harmful substances. An Australian study ranked psilocybin as third least harmful substance, just above kava and electronic cigarettes, while the UK classification ranks it as the least harmful of all the substances considered. In fact, both systems rank it as significantly less harmful than cannabis, not to even mention alcohol, consistently considered the most harmful. So this is exactly what Zach was talking about. Globally, several countries permit the use of psilocybin-containing mushrooms, and these include the Netherlands, Jamaica, Brazil, and others. Some of those countries, like the Netherlands and Jamaica, also permit the operation of psychedelic retreats, which offer guided psychedelic experiences. In other jurisdictions, possession for personal use is decriminalized for a number of drugs, for example, in Portugal and recently in Australian Capital Territory. In the US, since 2019, the number of new bills aiming to introduce psilocybin-related policies has been growing steadily. These enacted or proposed bills can be broadly divided into 5 categories that capture the key elements of different approaches. The first model introduces decriminalization through abolishing of all penalties or defunding or deprioritizing enforcement. Other jurisdictions go only as far as setting out frameworks for clinical research, while others set up task forces with an aim to develop the psychedelic policy in the future. However, some jurisdictions have been steadily progressing towards a system of regulated, supported adult use, where licensed operators can provide assisted psychedelic experiences or therapies outside of the strictly medical context. In Oregon, no prescription is required to access psilocybin. However, only licensed providers can dispense it, and the use must always be associated, must be assisted by a licensed guide. Under this system, clients can access assisted therapy for any reason, including seeking spiritual growth or pure curiosity. Other jurisdictions opt for a medical model where psilocybin or psilocybin-assisted therapy can be legally provided as strictly medical intervention. This is the case, for example, in the Canadian state of Alberta. The model offers access based on prescription from a registered psychiatrist, which can only be given to a client diagnosed with a psychiatric disorder. The system requires administration in licensed premises. However, it also allows takeout psilocybin for microdosing. What's interesting is that a variation of the medical model is possibly already something that could take place in New Zealand under existing legislation. The Misuse of Drugs Act and later regulations give the Minister of Health the power to approve prescribing of Class A controlled substances under defined circumstances. So this mechanism was used for therapeutic cannabis before medicinal cannabis scheme was introduced, and it continues to be used for several controlled substances, including stimulants for the treatment of ADHD. I'm not aware of any prescribers trying to prescribe psilocybin in clinical practice in New Zealand, and I wonder what the outcome of the application would be. If there are any psychiatrists in the room, I would encourage you to consider that to see the outcome. But a more robust system would likely be necessary to deliver psilocybin-based therapies equitably for those who could benefit. So after all, we've got this substance with very promising effectiveness data for a range of mental health conditions with very little evidence of risk of harm. We know that a sensible and risk-proportionate system of regulation is the best way to reduce harm, whether it's through a medical model, supported or not supported adult use, or combination of both. The aims should be around maximizing the benefits and minimizing the risks of harm. If there are benefits for mental health outcomes, then it is really important that the framework ensures equity of access as well. And we know that it's not so easy, as equitable access hasn't necessarily been the case for therapeutic use of cannabis in New Zealand so far. Adequate monitoring and evidence gathering may be quite important too, particularly in the context of substances where lack of incentives such as patent protection makes it more challenging to secure funding for expensive trials. Economic impacts of the system should also be addressed, including the potential for economic innovation, but also keeping in mind some of the principles of just transition. And finally, a system must account for tino rangatira and the rights of tangata whenua to govern the use of taonga species in a truly autonomous way. I guess I haven't proposed a system for Aotearoa quite yet. I guess we still have quite a few questions left to answer, but I think it's about time that we start answering those questions, as New Zealanders are already using psilocybin and psilocybin-containing mushrooms with legal and health risks that could be avoided. Thank you for the chance to share those reflections, and looking forward to the discussion. And once again, thank you for everyone.
Thank you, Jacek. Just before we proceed, some of you may be wondering exactly why psychedelics do these things that seem like magic, and it's probably worth explaining, and I'll get the nod from these guys if I get it right. One of the reasons is there's a set of structures in the brain called the default mode network, which sort of runs in the background and gets you through your day, but is also associated with destructive, repetitive things like addiction and anxiety and depression. Psychedelics take that part of the brain offline and let it reset. At the same time, parts of the brain that never get to talk to each other because the default mode network's in the way suddenly start talking to each other furiously. And that is the basis of the way change is enabled. Did I get that roughly right? Good. Suresh, you mentioned the decision of the TGA in Australia to reschedule psilocybin and MDMA for prescription. You have a particular insight on this because you're on the advisory panel. How are they going?
So TGA has delegated the policy making to the Royal College, and I'm on the steering group for that, not part of the TGA itself. Honestly, it's a bit of a show. And it's a classic case of where the bureaucracies have completely made a dog of it. Because what's happened is that someone in the Morrison government decided, yeah, we need to put like $15 million into this research. So they did that, and they put that through their bureaucratic arm to their policymakers that were distributing these grants. And then independently, the TGA kind of like, okay, let's do this. There's zero consultation with like First Nations people or patient groups, and then the medical professional bodies, they haven't been consulted, and now they're trying to pick up the pieces of this decision-making process. And then there's all this complexities of state law in Australia to navigate. So it's a real mess, and the college is trying to pick up the pieces of this. So it's a real case of like, if you're going to do this, you need to have like a clearly thought out, like straight up vision. So we got a lot we can learn there from Australia, the kind of way Australia implementing it. But maybe we don't have anything to learn because our government doesn't appear to do anything. So maybe we don't have to learn that lesson. But if we did, and the government by some miracle did do something, then we can learn that lesson about actually you need a clear direction, consultation, and streamline it.
Manu, I wonder whether the danger is of a repeat of what happened with something you were involved with, which was medicinal cannabis. It was medicalised, there was no skill base, and it hasn't gone well. Is that the risk in your view?
Yes, and I guess that's why we're interested in alternative regulatory pathways so that we avoid some of the bureaucracy and bureaucratising and corporatising of the medicine and the practices. And looking to the Y262 report, there was some pretty strong advice there around a parallel regulatory pathway, and the New Zealand government hasn't really entertained that to date, but neither have they been presented with what that might look like. And I think it's not about just a free-for-all and whānau can do whatever they want. It's about having tikanga in place to guide that Māori are in control of and are comfortable with, and there's a consistency there that parallels the kind of consistency and predictability that we expect in our medicines regime. So I guess that's the goal that we're working towards. Whether we get there or not, we'll wait and see.
Mitchell, it's sort of interesting, and you're a scientist, you deal mainly with with material things, and yet I think there's not much disagreement that any move forward with this kind of therapy has a spiritual element. It has, you know, whether it's the Freudian model that MAPS are driving towards FDA approval in the States, or whether it's what you and Manu are doing. And I think that even psychiatrists have accepted that, haven't they?
Yeah. And so while it's altering consciousness, that's obviously got some relation to our spirituality, being a spiritual being. And so this kind of leads us to one of our focuses is trying to use the whole mushroom, which is hard for science to wrap its head around. They always want to try and extract out one part of the taonga species and study that for good reason, because then you can be rigorous around the science. But perhaps you could see the mushroom as having a wairoa itself. And so all of the components of the mushroom are very important to the experience. And we see that in other indigenous cultures, that they find that their cactus, for example, is different in their experience between different regions. So you can't avoid the fact that we seem to have a spirit, and it does alter our consciousness, so it does start to bring these questions into light. Yeah.
Zach, you in a way personally represent a sphere that's actually quite a lot bigger than anyone else on this stage, and that's community use of psychedelics. You've written a book about it, but what are the constraints on you that what you're talking about is still a Class A controlled drug in the Misuse of Drugs Act? How hard does that make it?
So it hasn't affected the way that we can talk about it. You can talk about past experiences, and that's essentially what the book is. What it has done is, especially for my sister, because we're in the public eye, we don't want to get caught or have any heat come on us. So she's had to move to another country in search of psychedelic-assisted therapy. For me, it was okay. I'm kind of over that hump. I would like to be able to continue to do big dosages and further better myself as a being. But we've just had to put that on hold now as we're in the public eye. As for some people in the book, they chose to remain anonymous, and some people decided to pull their stories last minute out of fear of backlash or judgment or potentially losing their job. So that's kind of where it's at.
But I also, by the same token, get the feeling that community attitudes have shifted. You can read non-scolding stories in the newspaper about psychedelic therapy and psilocybin in particular. Are you seeing that as well? Who are the people who reach out to you?
There's been a huge shift, actually, and I think that's a lot to do with how easily we can access information. The people who have been reaching out to me are actually men sort of in their 40s and 50s, which was surprising, but awesome to have. I think there's also been a huge shift just because it's sort of becoming talked about more and more often. Netflix had a series, Fantastic Fungi. People have heard of the McKenna brothers, Terence and Dennis, and Paul Stamets is a big player. Even Joe Rogan with his podcast, he talks a lot about plant medicine, and so that reaches such a huge audience. I think the other reason is just people are sick of being sick and looking for maybe another way or an unconventional option.
Jacek, the Drug Foundation has, you've basically called for decriminalisation as a first step, haven't you, rather than what's happened in Australia. Am I right in that?
Kia ora, yes, I guess so. I think that decriminalisation is probably something a little bit different to implementing a robust and good framework for psychedelics for therapeutic reasons, but decriminalization is an essential first step. I think that there's very, very clear evidence that criminalization of personal possession, use, and social supply does not have any public health benefits, and it leads to exacerbated harms. These are situations where people cannot reach out for support. Any risk associated with psychedelics is really, really related to misidentification of the species. So in a situation where someone's exposed to, I don't know, poisoning because of misidentifying the species. People are just simply afraid to, go to to call the ambulance because of the risk of criminalization. So decriminalization is an essential first step for that. But another step, which something that you called medicalization, but I think there may be a system, and that needs to be developed for Aotearoa in partnership with Tangata Whenua and with communities that already use it. There is a potential for a system that's not strictly medical, but is somewhere hybrid, so community provision in community settings to reduce harms and maybe reap some of the benefits.
I wonder if the other risk we're seeing emerge in the US is therapeutic abuse, because people are quite vulnerable when they're going through this kind of therapy, and there have been a number of reports of basically cult-like behaviour. So does that suggest that there should be a degree of regulation over what kind of therapy, over how therapy is conducted?
Yeah, I believe so personally. I think that there is exactly what you just described. So I think that people are in an extremely vulnerable situation, and we have heard reports as well. I think they continue to be quite rare, but it is a real risk. So with every medical therapy or quasi-medical therapy, there should be a framework to mitigate that risk. And I think that this is why New Zealand really deserves a system where psychedelic-assisted therapies are provided in a safe way to people who could benefit from them, because quite often people who reach out for them are already in vulnerable position due to mental health issues or acute distress even. So absolutely there should be safeguards in the system.
The other issue with, I think we've established that the therapeutic component of this is very important, the talking part. But the problem with that is it's very expensive. Mitchell, I wonder whether you have any thoughts on whether we're going to, we've talked at this conference already today about access to medical care. We could be heading towards a situation where Australia finally gets its act together, and like abortion in the 70s, people who can afford it fly over, get the treatment and come back. How can we avoid that? Because the talking part's really expensive. A MAPS cure for PTSD is $20,000.
Yeah, I agree. Our main concern is around accessibility, that it should be equitable. And so maybe that's part of what we're trying to address with our study, is that it should be community-led. I agree that there should be some kind of frameworks and regulation around it. And maybe I agree that the psychotherapy is the expensive part, but maybe it can be scaled up through something like an app or something that assists with that, because the main concern is around accessibility.
Suresh, you didn't mention your own research, but I'm actually going to ask you about it. The first data is coming back from the phase 1 trials of microdosing, and that has, tell us what happened and what implications that might be for have for delivering the therapy.
Yeah, so I guess to let people know, microdosing is when people take much smaller doses of these substances, but they take them more regularly, maybe every third day, say, for a month or two. And people have claimed to the community that this is also quite a beneficial thing to do. So, and it's actually potentially a lot cheaper. Because actually the drugs don't cost very much, you don't need a therapist. We've actually designed an app that actually is going to accompany the people microdosing, and we're about to start our first phase 2 study in patients with depression, so using app-assisted microdosing therapy, and we'll see how that goes. But the idea is that that intervention would only cost about maybe $500 to knock that through before the company makes a bit of a profit margin on it, but yeah.
The other thing, you're so modest, the other thing that's emerged in this first data is that there was something to look at, because it wasn't apparent before these guys started that there would be. And the thing they did differently was allowed people to take their doses out in the community and go about their lives. And suddenly there were effects that hadn't been there when they were sitting in a room being looked at by scientists. Which kind of, it's interesting how much of this underlines the anecdotal knowledge and things like set and setting. And Manu, I wonder how that's likely to play in what you're doing. Because I can just imagine that a course of therapy will be a very different thing undertaken on a marae in that setting than it would be in a clinic with white walls.
Yeah, we're still working through the details of exactly sort of what the process looks like, but my understanding is that these sessions and these experiences are most beneficial when there's a clear intention going into it and also good support coming out the other side. That doesn't have to necessarily be with a psychiatrist or even a psychologist, but the challenge for us is getting a team who we're comfortable and others are comfortable that they've got sufficient training to be safe and effective in those contexts. So as others have alluded to, that there's very little, there's nothing really available in this country, and the training that's approved in other places is really expensive to get to. So we're looking at some opportunities to bring some of those trainers here, but also to build on the good work that's happening in both in clinical and non-clinical therapeutic settings around the country for other modalities and processes, so that we can build our own indigenous process and training package for our whānau to be supported. And all of that's going to help, ensure that it's not an expensive process, hopefully, along with the cultivation not having to be in Fort Knox and those sort of things like we have with cannabis or have had. So yeah, very keen to ensure that, as Mitchell said, it's accessible for the people that really need it.
Right, we're going to have to wrap up now. If you want to hear any more, you're going to have to be my taxi driver. But before we do that, I want a really quick thought from each of you on where you think this will all be at in 10 years' time, starting with you, Manu.
We might have magic mushrooms on our table with at these events to help us get through the day, I don't know. I think there's opportunity across the political spectrum, I hope, for open-mindedness, and would certainly welcome those officials and politicians to come and experience. That part of the training is an experiential thing, so those that want to be guides and support. Our kaupapa is going to be based at Rangiwaho, but hopefully there's other marae and communities around the country that can build on what happens there and elsewhere to make sure that it's spread around the motu.
Cool. Jacek.
I would say just decriminalized, most certainly, and we'll have a robust system that makes it safe for people. That's what I hope.
Cool.
In 10 years, why would you do therapy without using these catalysts? Everyone that goes through it says that you can achieve 10 years worth of therapy in one session. That's how therapy will be done in 10 years.
I'd like to see decriminalisation and psychedelic-assisted therapies, hopefully well within 10 years. And just quickly, if anyone's interested in learning more about the book, you can find it at bluehoney.co.nz.
I guess I would close out on a cautionary note that actually this isn't the first time that we've had a wave of psychedelic therapy in the world, and the first wave was in the 1950s. And that was kicked back, and I would like to dispel the myth that was because of the war on drugs. It was because of over-enthusiasm by clinical researchers and medical professionals that got carried away with the potential for this and used it without due care. So I would like to think that in 10 years' time, we haven't repeated that cycle.
Right. Beware of evangelism. Thanks very much to our panel. As I have indicated, I could have talked about this for another hour, but I think we got across some important things there and what some of the issues are. So please thank them all.